Thank you, Mary. And I think Mary would have said as well about, we're keen to expand the number of hospitals that are involved in patient-level costing, so you know where to contact. So next presentation is Fiachra Bane, who's our head of data analytics. And Fiachra is going to present on the ABF price list and the pricing framework.
Thanks, Brian. So as Brian said, I'm Fiachra Bane. I'm head of data analytics here at the Healthcare Pricing Office. I'm just going to give a quick presentation just on the price list and the pricing framework and consultation process that's going to come around that. I'm going to start with the price list. Most of you are probably familiar with it, though probably hasn't seen such a high profile in the last couple of years, given that all that we've gone through and the reversion to block funding, but we're very much getting it back on the agenda now, and kind of want to get the message across as why it's still relevant. Just to give the background of it, I mean, the price list in one format or another has been around for quite a number of years. Certainly predates me being involved in case mix, but it got changed into a price list when ABF was introduced in 2016 for the first funding cycle. In that changeover, there was probably a couple of years of myself and Brian and a lot of other people scratching their heads trying to figure out how we change this cost list essentially into a price list that can dovetail with funding and make that happen. But to be fair, we did get it up and running. We were able to get across all the hiccups, and for quite a while there, from 16 to 19, we had a quite fairly stable price list and annual inflation running around 5% on the base prices over that period. And then, well, I'm going to say it anyway, even though everybody else has been saying it, but COVID hit us, and our world turned upside down. Our personal lives, our work lives, the hospitals, everything. So what we started to see in the hospitals was high ICU demand, quite a change in the patient profiles. So some patients we would have seen coming to our hospitals just weren't anymore. Obviously, there's a big increase in respiratory illnesses, mental health illnesses as well. Huge demand for additional capacity in the beds. A lot of patients were now referred to the private hospitals, as both Brian's mentioned earlier on. There's a huge amount of focus on PPE, infection control, different pathways for COVID and non-COVID patients. And as most of things end up with longer waiting lists. And if that wasn't enough, we came to 2021 and we got a cyber attack. So extensive system outages, including hype, gaps in data collections, most of which I think are filled at this stage. But because we had missed appointments, it was quite difficult for us to tell where we had a data gap and where there was actually a gap in the service. And yet again, waiting lists. So the result of all that really was, at the very highest level, reduced activity levels because the hospitals emptied out, and increased costs because there was a huge amount of additional funding put in for COVID-19. But that's only the surface level. Underneath that, there were big differences in the profile of the patients that we see in the hospitals, and there were big differences in the profile of how we were spending our money. So actually, the third point here is the big one, the relationships that underpin an effective ABF model. They just didn't hold anymore. It wasn't that ABF suddenly didn't work, as a methodology. Nothing changed, it still does. But all of those underlying assumptions mean that we had some workarounds to do. And not only was it our response to revert to block funding, it was an international response as well, because the effects of COVID that we suffered here were exactly the same effects that everybody else, and Joanne spoke about those in Australia. I just dug this out. Certainly the relationship between costs and activity has entered a new phase, and I guess the point is we really didn't know, and still don't know, what's coming around the corner there. In this scenario here, I think I'd be safe enough because my wife's a power walker and I'm just lazy, so she'd be taking one for the team. So what the numbers looked like in 2020, activity figures are down in the region of 200,000. There's a bit of debate on that. I think it's about 250,000 in the acute hospitals, but if you add back in what was displaced to the private sector, it's probably around 180, 190,000. But 16% decrease in activity year on year. Costs were up 400 million. I think Mary mentioned it was, 348 were actually, COVID costs, and there was just normal year-on-year inflation in that. The upshot of it was a base cost was up €1,050, 20% increase in base cost year-on-year, which is huge in the context of a usual 4 to 5%. Not only those headline figures, but when Mark and the team started looking at the reporting of COVID expenses by hospital, it was hugely variable and didn't always necessarily make sense in the context of the size of the hospitals. And it also led to a high variation in the observed benchmarking. So we did actually do a benchmarking exercise, as we do every year, for 2020. But what we did see in that, and it was kind of expected given what we saw in the costs, is that there was the range and the variation of the benchmarking results was extreme. So we went from a range top to bottom of 28 million up to 36 million. So not really an ideal starting point for price list development. So in our normal process, we would start with benchmarking, move forward from there. Once we saw the results, we kind of went plan B. So given that everything was gone wrong and the fact that we're actually blocked funding, then why have we bothered to generate a price list? Well, first of all, and Brian mentioned it, was ABF continuity, and it was important for us and in the HPO and everybody out in the hospitals just to maintain that ABF work cycle, to keep that information flowing in, because it was hugely valuable to us. And even the fact that over the last 2 years, no more than I'd say with everybody else, the work that we do in the HPO changed massively. The day job changed, and yet the day job still stayed the same, because Brian insisted it's going to be business as usual as far as ABF is concerned. And to be fair, that was a good call, because it has proved its value many, many times. It's still relevant to hospitals. We still produce our ABF monthly reporting. There are prices in behind that. What we'll have seen and last year and this year is that there are large gaps between targets and actual activity levels, because we're still being impacted by COVID and there are still additional costs in the model. But it is still worthwhile having a look into those reports. A couple of the big areas where we really reap the benefits was understanding the expenditure during COVID-19 pandemic and in relation to the private hospitals. So the private hospitals, we're paying a certain amount for that activity. Well, what would be the usual value of activity in the public sector to go with that? And there's been a lot of that type of question, and particularly as well in relation to the waiting list. So a lot of the information that we gather for ABF purposes has fed all of those projects. And finally, of course, the treatment abroad scheme are a user then of the ABF price list. So regardless of the fact that it's not being used for ABF purposes, we still are obliged to generate it for that purpose. This is as technical as it's going to get. I'm just going to bring you through the development process. So really what we decided to do was we were going to revert back to our 2021 price list. The reason for that is because it was based on 2019 costs and activity, the last unaffected year, so it was a good solid base. It also tied in with what was happening on the National Service Plan. That was what Brian mentioned earlier on, that Emer worked on. 2019 was taken at the base, and there were adjustments for that then based on reduced activity due to COVID, but also what the bounce back was towards the end of, end of the third quarter into the fourth quarter 21. So once we had those, we were able to apply that to, we had to take a look at the budget that was being awarded for 2022, and we had to do some sort of numerical gymnastics essentially to try and, out of that budget, what was ABF related, and out of what was ABF related, what was directly DRG related, because those are the only costs we wanted to include. So once we were satisfied that we had what we could term ABF DRG related budget, we identified the core activity from the National Service Plan. We excluded, a lot of new beds went into the system over the last couple of years, but they had ring-fenced funding attached to them. So we excluded the activity, projected activity for those beds and the ring-fenced funding, and came up with our base price as a result of that. And essentially then the last step is a calibration step, really. You're putting that activity levels and the estimated value compared to the budget. And actually what turned out as a result of that was a 4.5% base increase over 2021, which is very much in line with the usual sort of inflation pattern that we had been seeing. And we were happier that would make a better basis of a price list for a non-COVID environment. Weren't we very forward-looking? And I would say in the service plan as well, the activity levels for that were probably set up very optimistically for a non-COVID environment. But, you know, you can't really predict what's coming around the corner. I suppose the one thing that we didn't want to do was build in a whole lot of COVID costs into a price where, as Brian mentioned earlier on, those conversations are going on with Deeper and the department about what's recurring and what's not. We can't build non-recurring costs into the price list because we're just not going to have that. So there it is. I think there are hard copies available. It's on our own website. It's also part of the ABF monthly reporting tool. The full price list is in there as well. So the 2022 pricing framework. So the pricing framework is a new concept for us. I suppose you've heard Mary talking about all the very good consultation that goes on the costing side. And I'm sure Jackie will be up after me, and there's an awful lot of very good consultation and feedback on the coding and activity side. We don't do or haven't done that to date really on the pricing. I suppose pricing is a little bit downstream from those, even though the coded data and the costing data are both inputs. So people feel that they're inputting directly to those, whereas more downstream you're actually inputting to this, and this is what determines some of the funding. So what is it? Well, it's part of the stakeholder engagement process, and you know, it really outlines the methodology and process. So how we go about doing what we do in the HPO in relation to ABF. So the 2022 framework, it's a fairly short document. It's given a broad overview of all the steps in the ABF process: costing, data collection, pricing, funding. It gives a short description of all of those. Going forward then from 2023 onwards, essentially this document is going to be your update document. It's going to document what changes have been made in the current year in relation to pricing. But it will also be supplemented with a more technical, detailed pricing document. What it also does is establish a new consultation process, and this is really part of where the engagement part comes in. We really want to get feedback on these prices. They're being used to fund the system. I think Rick Marshall was over with us in, I don't know, was it 2013, 2012, to give us some of his wisdom in relation to starting ABF. And one of the things that sticks in mind that he said was, the price is always wrong. Now, it sounds like quite a negative place to start from, but actually, if you want to engage and refine constantly, coming from a position where the price is always wrong is a good position, because it means you're forced to look at it and change. And we really need the engagement of people on the ground, frontline staff, clinicians, to start feeding back to us, the finance people, feeding back, you know what, this price doesn't really make sense. I mean, we set the price based on the data, but we're a couple of steps removed from the reality of what that is. So we need that feedback to refine it. The other thing that the pricing framework will do will feed back on the consultation process. So we want to gather your views on the prices, or the process, and the items that we'll have reviewed in a given year, we'll report back on and say, well, you know, we looked into this and yeah, there was a case to be made, so we've made these changes, or we've looked into it and, you know, we feel that there's insufficient evidence to make a change at the moment. But it's all about that engagement and that transparency as to what we're doing and why we're doing what we're doing. What does it contain? And go through these fairly quickly. It's available online at the moment, and I would urge you to, you know, to have a look at it. But it goes to the sort of overarching, you know, pricing guidelines, process and system design guidelines. It talks about the scope of ABF, so it's currently admitted patients, but, you know, we are looking about going into ED, outpatients, and eventually community. So all of those changes and progressions will be flagged as part of that. It talks about the classifications that we're using. The document will flag any changes or upcoming changes in classifications. It talks about data collection, you know, what data we're collecting, what we need, how we do it, and how people can access that data. There is a section, a high-level section on the price setting process, because we're aware that there isn't a document out there currently that has that fully set out. It talks about funding, so what are the funding sources, what happens with private patients. There's a piece on insourcing and outsourcing, which has become very relevant, given what Brian McCarthy and Brian Donovan have been working on lately in relation to the private hospitals and waiting lists. There's a section there on stability and how we try to assure that the prices are as stable as they can be year on year, while still reflecting clinical practice and changes in underlying costs. And then the piece on policy development, how we're going to go about that, and, you know, what changes we're proposing to look at over the next number of years. So one of them is work in progress. You know, HYPE is a discharge-based data collection, so we don't get visibility in our funding model on anybody who's currently in a hospital, particularly at the end of the year. So you end up with a situation where you could get funded you'll get funded for that patient in a discharge, and from the work we've done, we can see that we can't rely on the whole, you know, swings and roundabouts kind of idea. It does swing significantly, could be plus 1 or 2 million for a given hospital in a given year in that work in progress. So we need to find a way to deal with that. And to be fair, Brian's team, Joe, Shane, have been working on that. So who's the document aimed at? Pretty much anybody who's any involvement or interest in any aspect of ABF, because it really is an annual update as to, you know, what we're doing. So, you know, HSE group, hospital managements, finance and costing staff, clinical professionals, coders, coding managers, clinical programs, researchers, literally anybody. And it's a, you know, it's a short document. What does orange mean, Deirdre? About 3 minutes, okay. That's okay. Yeah, that's grand. So I'm not going to read through all of these because you can get them, but just it gives kind of the overarching guidelines and principles that we try to operate by in the HPO. So timely quality care. Obviously, we don't provide that in the HPO. That's not our role. That's the role of some of our colleagues here, but we can support that through the pricing. Efficiency, again, are we treating people in the most efficient manner and settings? Fairness. Is the funding going where it needs to go? And a big one for this year, I think, as part of the theme, is system responsibility. So I think when we set out on the ABF journey, it was very much seen as a HPO-owned thing. I think more and more, and certainly in the implementation plan, it talks about a shared responsibility between ourselves, the wider HSE, and the hospitals. You know, it's a funding system essentially for the system, so we need everybody's involvement in it. Process guidelines, transparency, administrative ease, stability, evidence-based. A lot of these are the kind of principles that you would see in terms of ABF. They're certainly mentioned in the implementation plan. And system design guidelines. I'm not going to go through all of these, but ABF preeminence is a big one. And I think we probably owe that particular one to Jennifer, who did a lot of work on the implementation plan. And the message really was, you have to make ABF be the funding system, and make it, you know, everybody has to buy into that. So really the take home on the pricing framework, it's not a technical document, so you're not going to get bogged down in it. It gives you a brief snapshot of the current status and the planned developments. And it should be your go-to document, really. If you've got questions on ABF and what's going on at the moment, that should be your annual checkout, as well as getting on the phone and asking, the guys in the HPO, but that'll be the official documentation of it. So just to finish up, we want to hear from you. In April 23, we will have a first annual pricing consultation. That will be launched after the pricing framework next year. And what we'll try to do is we'll review submissions that we get each year, consider them what's going to be changed in the price list, what will be included for the work plan for a following year. It may be just a bigger piece of work, that can't be fit into a particular year. There may be suggestions that are outside the scope of this document, but they may well fall into the scope of the HPO. They may be costing queries or that type of thing. And some may just be beyond the remit of the HPO, but you will get an answer back on all of those. We will give details in the scope of the topics that we want, what a pricing submission should contain, and the principles that the decisions will be made on. So in terms of scope, we're talking about, yes, we want to hear about the DRG prices, ABF co-payments, the pricing methodologies. Capital items are out of scope for ABF, so there's not really any point in including those for all us, and overall funding levels as well. But they're out of our control, so I'm afraid Brian, generously as he is, he doesn't hold the purse strings in this case. In the content, what we'd expect to see are, a statement of the issue, supporting data. There's been a lot of talk about evidence-based decision making, so we will need to see the data. Proposed solution and a demonstration of the impact that you believe that change would make. And then in the principles, evidence-based, it should be fair and equitable. So, we're not going to put anything in place that we believe is going to create unfairness in the system. We want to find those legitimate things that we need to fix in the model. PLC preeminence is definitely going to be one of those. So when you come to make a submission, we want to see the evidence of that through the PLC data. It may not be there, and that may be a pointer that we need to, work more on our PLC data and our hospitals and the detail of our submissions. But it's going to be the source of our evidence. It'll have to be administratively feasible. We won't be able to set up new data collections for everything that people might suggest. We're going to have to rely on what's already in existence. And again, clinically appropriateness as well. So we are having much tighter links with the clinical advisory group, and we will get the clinical input and all of those things. So just to say, that's a flavour of what will be in the guidance in that document. Don't take it as written in stone, but it's pretty much there. So we'll be starting that in 23, but I would like to hear from you before that. We've lost a couple of years because of COVID. We don't want to lose another one. So if you have the price list, you'll have the framework document, have a look, and if there are issues that you find in your hospital, you think that there's an issue with the pricing or the methodology, let us know. We may not be able to address them this year, but we will get to them. They will be put on the list for addressing at another stage. So if you do want to send in a submission, there's my email address. If you could just put pricing submission in the subject line, just so I can keep them all together and keep track of it. And I think part of the reason why that list was drafted earlier on is if I can get some submissions in this year as well, it'll give us a better flavour of what type of things we might be getting, and we can produce some stronger guidelines. And that's it for me. Almost on time.